Good afternoon, everyone. It has been a very European-focused discussion, at least the parts I've heard so far, and I'm actually taking a different perspective, as she mentioned. I think if you were a clinician who was faced on a regular basis with women with advanced ulcerating breast tumors or hospital wards that are half filled with women with advanced cervical cancer, you often would feel that prevention and early detection are luxuries that you can't even begin to think about in developing countries. And yet, the point I think we need to emphasize is that's exactly where prevention and early detection are most important, because resources are scarce, and we have to use them most effectively. We know that prevention and early detection are the best value for money that we can have. For the past 25 years, I've been working with PATH, which is a nonprofit global health organization based in Seattle, but working on finding affordable and effective ways to reduce breast and cervical cancer, working with dedicated colleagues in Africa, Asia, and Latin America who have that same goal. And why are we so focused on cervical and breast cancer? A quarter of a million women die from cervical cancer every year, and 90% of those are in developing countries. And another 500,000 women die from breast cancer. And I think some of you might be surprised to learn that more than 60% of those are also in low-resource settings. Today, I would like to just share with you 3 examples of how innovation can help foster prevention and early detection, even in low-resource settings. So the first example is one that has already been mentioned here, HPV vaccine. And it's been available for 10 years now, and it's already having an impact, and we're seeing this in a lot of studies that are coming out. If you look at the countries that started right at the beginning, Australia, UK, several European countries, Canada, and who've been able to mount studies, we're already seeing a drop in infection rates and even in early cervical disease, and that's in just 10 years. Even in the US, where coverage is much less than optimal, we also are seeing an impact. We're seeing even a benefit among those who didn't receive the vaccine. So we're seeing a herd immunity, a herd protection effect, which gives us hope for the low-income countries that are just getting started. Fortunately, we have support from Gavi, the Vaccine Alliance, that subsidizes the vaccines for low-income countries, and more than 20 low-income countries have already started to introduce HPV vaccine, either on a pilot or a national scale. So I think we have some hope that there's a tremendous potential here to see a dramatic drop in cervical cancer in the next 20 years. If we're seeing these benefits on cervical disease this early, I think we're going to start seeing in 20 years, when our 10 and 15-year-olds get into their 30s and 40s, a drop on the incidence of cervical cancer. So that's one exciting prevention area. But we have a generation of women who are already beyond the age when vaccine can be most effective for them. And for those women, they need screening. And traditional screening of pap smears, and even in low-income countries, the more recent approach of visual inspection with acetic acid, are not getting us where we need to be. But with HPV testing, particularly HPV DNA testing, we have hope now also in this area of secondary prevention for cervical cancer. And we've seen that there are HPV tests that have been available in upper-income countries now for more than a decade, and some of them are part of primary screening, some of them are part of co-testing or reflex testing. But I think the role that they might have in our low-income settings has really received relatively little attention. But they could revolutionize screening for us in low-income countries. In our work in the last 8 years, we've demonstrated that at least one HPV DNA test performs satisfactorily with vaginal samples that women can collect for themselves and hand over to the lab for testing. Now, why is this important? This could be a complete change in how the work is being done. In the same way that mobile phones allowed low-income countries to jump over the process of developing landlines and extensive networks, HPV testing that's self-collected could enable countries to leapfrog over the old technologies of cytology without having to develop extensive networks of laboratories and pathologists who've had years of training. This would allow us really, along with targeted screening schedules, to overcome one of the biggest problems that we have in low-resource settings, which is a chronic shortage of health workers. And if, for example, the higher sensitivity of HPV testing allows us to screen less often and yet still have the same benefit that we hope to have, and with HPV testing, if it were self-collected, you don't need a health worker to be doing an extensive gynecologic exam, except on those who are positive and need treatment. So we could reduce, we expect the positivity rate to be perhaps 10 or 15%. That would reduce by 80 to 85% how many women have to be actually examined in a health center by these overworked health workers. So this could reduce both cultural barriers, barriers of modesty where women don't want to be examined and have intimate exams, or where their culture says certain health workers, especially male health workers, cannot do such exams. It would reduce the burden on our healthcare systems that we know are struggling, and it's actually much more effective in preventing cancer because of the sensitivity of HPV testing. So this is another innovation that's feasible and helpful to low-income settings. The third example I choose from the area of breast cancer, where we have fewer prevention opportunities, but where we already know that early detection makes a huge difference. Early detection allows less expensive and less invasive treatment, and it also improves not only the length of survival, but the quality of life for women if they can have these less extensive treatments. Innovative approaches for breast cancer involve really a combination of old and new technologies in our experience. We know that in our low-resource settings, it's going to be years or perhaps decades before mammography or MRI or immunohistochemistry become widely available in these kind of settings. And so we're looking for other ways to try and ensure that women are diagnosed earlier and can benefit from that. In a project we've been doing with the government of Peru for the last 5 years, we've actually combined some old and new approaches. So we trained first community health workers, something that's pretty standard in a lot of developing countries. Trained them with basic messages about breast health, about danger signs that they should seek care for, and then trained community midwives to do a clinical breast exam instead of mammography. They can find a lot that way. Trained local doctors at the community hospital to do ultrasound, very simple ultrasound, and then fine needle aspiration biopsy. And link all of that to a regional cancer center for treatment. These 3 examples have all been designed, evaluated, and then subsequently refined to be suitable and sustainable for low-resource settings. We know that it's possible and, in fact, essential that low-resource settings get the best value for money that they can have. We also know that if we do these things and ensure that people use strong evidence-based prevention programs that are based in communities but linked to treatment, that even in the poorest countries, many lives can be saved. Thank you.
Oh, thank you very much. Very profound. So are there opportunities within existing programs like that you can kind of piggyback onto in these countries?
Well, I think that this last example of Peru is where we have built on existing structures that are already there. A lot of countries have developed various types of community health workers, for example. Ethiopia has their community extension workers, and many communities have volunteers who can take this message out. And we know that education is one of the most powerful things that we can put in the hands of people to protect their own health.
And is there any resistance to the vaccine strategies that in some nations over other nations, and do you perhaps use some educational assets to maybe address that? I was wondering if you
Yes, it's interesting because when the vaccines first came out, the issues that arose in the United States were quite different, and there was a lot of controversy, as some of you may remember. We went to several low-income countries where we had a project to introduce the vaccine, and those were not the issues that came up. They were very different issues. One of the big concerns, for example, was fertility, which was not a concern in the US, but was a fear in cultures where fertility is terribly important. And the big question was, is there any risk to our girls? You're getting them at such a vulnerable age. So the messages do have to be tailored. And we've seen some communities where the church or the faith community of various types has raised concerns about the vaccine, where you have to address them directly and work with faith leaders to answer their concerns. But it does vary by country a bit.
Interesting. So at this point, thank you very much for what is a very pragmatic approach, I think, to prevention, especially in acknowledging the disparities and the differences of what different countries have to work with.